Today we are going to talk about metabolic acidosis. I would strongly suggest to look at the introduction video to acid base. I'll include the link in the description. So the focus would be primarily on metabolic acidosis today and how to think about it. Metabolic acidosis refers to the non-volatile acid path. That means your sulfuric acids, phosphoric acids, uric acids, and also transient acids like lactate and ketones. My goal is to keep this talk fairly simple so that you can apply it on a day-to-day basis. The goal here is not to be comprehensive, to be of practical use. Okay, an important part of understanding metabolic acidosis is understanding anion gap. Remember, our body has positively charged ions and negatively charged ions. They should always be balanced. If they are not balanced, we will be having an electric charge, which is not the case. We are electroneutral. But we can measure uh, a lot more of the positive charges rather than all the negative. So the major positive charge is sodium. In some of the older anion gap math, they used to include potassium as well. The major negatively charged is chloride. You have chloride, and this next one is bicarbonate. We never uh, talked about albumin, but albumin is also negatively charged. That will be somewhere around here. And then you have your phosphates, sulfates, citrates, all those ions that are in this, what we call the gap. So a gap, the anion gap is more of what we are not measuring. So just to reiterate, anion gap is the negative charges we are not measuring. So we all have a normal value for a normal gap because in general we carry some phosphates, sulfates, citrates, albumin, which we don't measure. Let's talk about non-gap acidosis and just get it out of the way. This is a scenario where you have a loss of bicarbonate and you replace it with chloride. That means you have an elevated chloride and a low bicarbonate, but your anion gap is normal because you never really change the concentrations of any of this. This can happen because you have bicarb losses from GI tract, or you can't excrete proton in the kidney, or you lose bicarbonate in the kidney, which is RTA. The most common reason for non-gap acidosis in the hospital is normal saline. Let me reiterate, there is nothing normal about normal saline. Normal saline is relatively acidic to the body. If you have good functioning kidneys, the chloride, which is 154 milliequivalents, which is way more than your maybe 105 here, chloride gets exchanged with bicarb in the kidney, and you don't develop uh, a non-gap acidosis. But if you have any renal impairment and you flood them with a lot of normal saline, you can get into non-gap acidosis. This is more of an intellectual curiosity. I wouldn't say we would spend an awful lot of time managing non-gap acidosis in the hospital, especially in an ICU setting. So just so that you understand, in non-gap acidosis, the gap is anion gap is normal. That's why it's non-gap acidosis. There's nothing magical about it. That means you lost some bicarb or you have too much chloride. Let's say you damage someone's kidneys for good. Over time, you will have the sulfates, the sulfuric acids, the phosphoric acids, all of these accumulate, and your bicarb will start trickling down, and you'll be having an increased anion gap. The classic patients are your end-stage renal disease patients. If they don't get dialysis for a few days, they have an increased anion gap because they have all this junk accumulating and taking up that negative charge space. Because you don't measure it, your anion gap is up. This is the standard non-volatile acid accumulation. Easy to pick up, and we can work on it. But the next criteria, the next topic we are going to is where if you have transient acids causing a gap, that is where the anion gap becomes extremely useful for us. Let's say a patient has an ischemic leg. That tissue is not getting oxygen, so it's going to generate lactate. Go back to my introduction to acid base to understand why lactate is generated. As the lactic acid increases, it is going to start occupying this space. So your anion gap increases. That's one scenario. Lactic acid is a whole talk in itself, which I will be doing subsequently. The other major contributor to anion gap in clinical practice is ketoacids. Again, go back to the introductory talk to understand these transient acids, lactate and ketoacids. These are the ones that you need to worry about, pay attention to, especially through the anion gap, to better understand what's happening with the patient. I always look at a anion gap because that's easily available. This is the first test you're going to get when someone comes to the ER. You look at a basic metabolic panel, the anion gap is right there for you. If the anion gap is elevated, you got to figure out why. Quite often in acute care situations, you're dealing either with lactic acidosis or ketoacidosis, and paying attention to that anion gap will lead you down a path of subsequent investigations where you order your lactate, beta hydroxybutyrate, which is your ketone, and then you will start going deeper. Why is this patient's lactic acid elevated? Why is this patient's keto acid elevated? So pay attention to the anion gap on your basic metabolic panel. If it is elevated, order your lactic acid and beta hydroxybutyrate, and then investigate further based on the results you get. Lactic acidosis and ketoacidosis are talks by itself. And then we'll move on to the blood gas, why we need a blood gas. In addition to confirming the acidosis, we need to look for compensation. That would be the next part we'll be talking about. We have addressed this before. CO2 is the major acid. It combines with water, forms H2CO3, becomes a proton and bicarb. And you're getting your metabolic acids like sulfuric acid, which give a proton. Your transient acids, if you have a lot of them, like lactic acid, keto acid, they all generate protons. This is the proton that you're worried about when you talk about your pH. So let's say you run into a scenario where you have a lot of excess of these acids. The body cannot get rid of them because the primary problem lies either with excess generation or impaired elimination of these. But it has some reserve with the CO2. What the body tries to do is it will start blowing off more CO2. So when you can't deal with a non-volatile acid, you have reserve in dealing with your volatile acid, which is your carbon dioxide, and you will breathe it out. This is where we come to the Winter's formula. So for a metabolic acidosis situation, the expected PCO2 should be 1.5 times your bicarbonate plus 8 plus or minus 2. This was achieved by a population-based study. How does it apply in clinical practice? let's say a young patient comes in with severe DKA, his bicarb is 4. Now his PCO2 expected in millimeters of mercury should be 1.5 times bicarb, that's 6, plus 8, plus or minus 2. So his PCO2 should be around 14. Let's say this patient's PCO2 is actually 30. That means patient's PCO2 is much higher than the expected. This translates to the patient has respiratory acidosis on top of metabolic acidosis. Then you'll have to figure out, why does this patient have respiratory acidosis? Is he tiring out because he's been compensating for a long time, like breathing hard for many, many hours? In that case, you may either assist the patient with BiPAP while you wait for the DKA to resolve quickly, or you may have to intubate. This scenario far more happens in lactic acidosis, because severe lactic acidosis is usually secondary to major pathophysiological derangement in the body, and the patient is failing to compensate. If the PCO2 that you measure is much lower than the expected PCO2, that means let's say his PCO2 is 8 instead of 14, that means patient actually has a respiratory alkalosis on top of a metabolic acidosis. So that's how Winter's formula is helpful. It will tell you in the setting of metabolic acidosis what the patient's compensation is, the respiratory compensation. If it's a pure metabolic acidosis and the patient is handling that metabolic acidosis okay, you will find the PCO2 exactly where you want it to be. If the PCO2 is higher, means there is a secondary pathology going on, either because the patient is tiring out, or let's say he has heart failure and he can't keep up with that increased work of breathing, so you may have to intubate sooner. The PCO2 is only 30, but you're actually intubating him sooner because at some point he's going to completely tire out and stop breathing. You don't want to wait till that point. So Winter's formula helps you pick up your patient's trajectory before they code. So pay attention to the bicarb, do your math with Winter's formula. It is a very simple formula, 1.5 times bicarb plus 8, and that's where your PCO2 should be. In another video, we will do some math so that we can have some fun with acid base, as well as talk about scenarios where a change in the ventilatory settings, how you can predict the expected pH.